We have very precise DNA sequencing tools. We can get down to values that were unimaginable even 5 or 6 years ago in terms of early detection states.
Thanks to science, a number of diseases that used to kill us are now preventable. For instance, current research suggests that at least half of cancer cases could be prevented. As a matter of fact, researchers right now are working to detect certain kinds of cancers before they even develop. And they're doing it by using your genome, your DNA, to determine your future cancer risk. This is known as personalized or precision medicine, and it's a new way to not only fight, but intercept cancer before it even starts. Joining us from Mayo Clinic is Dr. Mrinal Patnaik. He's a hematologist by training who runs the Epigenomics Development Laboratory, which is part of Mayo Clinic's Center for Individualized Medicine. It's good to see you, Doctor.
Good morning. Thank you, Kathy.
And also with us is Dr. Kelly Bolton. She is a clinician researcher at Washington University School of Medicine in St. Louis, Missouri. She has a background in medical oncology and genetic epidemiology. Her research looks at early interventions for people with a higher risk of developing blood cancer. Dr. Bolton, it's a pleasure. Thank you.
Thank you.
Personalized medicine and cancer care. That's what we're talking about on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Worser. Thanks for being with us. I think personalized medicine is really interesting. And I understand that it's medicine that uses information about a person's own genes to prevent and diagnose and then treat disease. When it comes to cancer care, though, Dr. Patnaik, what does personalized medicine really mean?
Yeah, Kathy, that's a great question. The advent of genomic sequencing has completely changed the way we approach cancer care. And so there are two terms that I would like to introduce, precision medicine and personalized medicine. So, prior to this, it was one size fits all. So if you had a particular cancer, regardless of whether, you were Asian, Caucasian, African American, or your hereditary status, you would get the same type of treatment. Now, with precision medicine, using DNA sequencing predominantly and other related techniques, we have identified certain genes that are frequently mutated in cancer types, and we have therapies that could match this. So, for example, if there is a mutation that can be found, we may have a drug that's either an oral drug or an antibody that could neutralize it. And so that is considered precision medicine. Now, when you take it to the next level and you have an individual patient that comes to you, and now you're able to do DNA sequencing, understanding their hereditary status, uniquely profiling their tumor status, and now prescribing therapies based on that information. That is called personalized medicine. And in my humble opinion, that is the way that oncology or hematology oncology should be moving.
As we talk about personalized medicine and oncology right now, where do you often find it being most used?
One exciting thing that I spend a lot of time on clinically is taking care of people that have an inherited predisposition to cancer. We know that cancer runs in families. We've known it for quite a long time now. And one of the benefits of getting tested for a genetic predisposition to cancer is that it can tell us about that there's certain screening strategies that we can use to detect cancer early in those people instead of when the cancer is diagnosed late, where it might be not curable or where it might require like chemotherapy or radiation therapy to treat. Depending on someone's inherited genetic makeup, we can screen early for certain cancers, and we've shown in large studies that doing that actually does really save lives and prevents cancers from being diagnosed too late.
People have, as you know, who have an increased risk of breast cancer, they can choose to take preventative steps like a mastectomy, perhaps. Because you're also, both of you are blood cancer specialists, how might this work, this early detection work with blood cancers?
Lots of credit to the breast cancer field for really leading the way. We wouldn't be here today, if 2, 3 decades ago, scientists, including, scientists like Dr. Bolton, hadn't spent that time, educating us about hereditary risk, how cancers develop on a hereditary background. And so we are fortunate to take that knowledge and now put it into the blood cancer space. And the other thing that happened, as Dr. Bolton pointed out, is we have very precise DNA sequencing tools. We can get down to, values that were unimaginable even 5 or 6 years ago in terms of early detection states. And so as we age, our genome is exposed to a lot of genotoxic stresses, whether this is in the form of radiation, chemicals, what we eat, where we live, what type of water we drink. And you combine that with certain hereditary changes that may have been passed down through our ancestors. And then this becomes a perfect melting pot, for certain changes to happen in the blood stem cell pool. We refer to this as clonal hematopoiesis. Clonal, indicating that there is something unique that is allowing these cells to be fitter and survive. And hematopoiesis just defines the process of blood production in the bone marrow. Both our institutes are leading the way and trying to take this, from the bench to the bedside so that we could actually implement this in maybe higher risk populations and try and replicate what the breast cancer field, has very well done with, the BRCA mutations and all the guidelines for women at risk with these mutations.
So these people are at a higher risk of developing blood cancer, but they don't have it yet. So in a sense, Dr. Patnaik, are we engaging in watchful waiting? I mean, that would seem to be quite stressful.
When doctors use the word, we will wait and watch, it usually translates into wait and worry for the patient. And I want to underscore that, most patients with clonal hematopoiesis won't develop leukemia. They're at risk. There are several patients who will die from other causes that are not related to leukemia. In fact, majority of the age-related clonal hematopoiesis that we see in the elderly are actually lower risk states. And what Dr. Bolton and others, including myself, are trying to work on is try to understand amongst these people with clonal hematopoiesis who is more at risk for developing leukemia, because they are the ones that we want to focus our attention on. At the same time, we do not want to over medicalize this situation. So if we can rapidly de-escalate in someone who has a chip mutation that we think is low risk, how can we reassure them, de-escalate, their care, their concern, and come up with a reasonable monitoring plan. Both of us are physicians at heart, Dr. Bolton and I personally believe very strongly that we should not make the cure of disease more grievous than the endurance of the same. So while there's a lot of enthusiasm on early detection and intervention, we have to be very careful about the long-term consequences of what we do in this space, which is why, we are working on these fronts. But if you ask me, the most important question for our field is accurately identifying that fraction of patients with clonal hematopoiesis who are either going to develop leukemia or who truly are at an increased risk of cardiovascular disease and dying. And while we have made certain steps, there's still a lot of work to do.
I agree. I think it's basically trying to understand the natural history of clonal hematopoiesis and identifying people that are at the highest risk. That's like the first step in intervening. We and others are starting to design clinical trials to target those high risk populations, because those are the you really only want to intervene if you have a pretty good sense of someone's risk and that it's going to help by intervening early. Because for prevention of cancer, you have to be really careful because these patients could be could be doing the intervention, taking the medication for a really long period of time. And you have to make sure that it's really safe and well tolerated and that the risk benefit ratio is favorable.
So you both would agree that there is interest, that it would be in the patient's best interest to know what type of cancer they are facing down the road, right? Given some of those caveats that you mentioned, Dr. Patnaik.
I agree, Kathy. I think, early detection is spreading across the spectrum of cancers in the human body. And there's certain cancers who've taken the lead decades ago. It's become routine to have mammograms. In fact, the USPTF has now recommended women to start mammograms at age 40, given that we are seeing almost an epidemic of early onset cancers in the breast and colorectal space. People are familiar with colonoscopies, PSAs for prostate cancer, now low dose CT scans for lung cancer screening. I think the key thing that all of these tumor groups have shown is that there is a clear benefit in early recognition of these cancers. So if you have somebody who has an early breast lesion, she can undergo a lumpectomy or a mastectomy and dramatically change the outcome. In our field, we still have to show that by detecting these clones early, we are truly going to improve their survival, without necessarily creating more complications or delaying progression, but at the cost that when it does progress, it's so resistant and it's evolved so much that it's still not going to make them live longer. So I think these are in ethical questions. I love the science. I love pushing the boundaries, but I want to remain practically grounded that, our first obligation to humanity is to make sure that safety is, really well established. And then there's a clear endpoint that we are truly making something better and not just treating, numbers or treating mutations without changing the outcome of the disease.
Do you ever encounter patients who just simply do not want this kind of information? And how do you deal with that, Dr. Bolton?
Where it comes up is I see patients that have inherited predisposition to cancer, and they're reluctant to get tested because, like you were kind of saying, there's the fear of the anxiety that could cause by knowing. But I try to, I'd say there's like several really good reasons to know. Number one is we would offer early screening interventions, and we know from big studies that it saves lives by doing that. It reduces the intensity of treatment that you would need if you got cancer. So it really does make a lot of sense in that way, and there's really good evidence supporting it. The second reason is it's not just for you, it's for your family. So, it's for your children, it's for your distant family members, so that they can also have the opportunity to know if they're at risk and whether they need testing and screening. And then, there's going to be some anxiety about knowing that you have, a genetic predisposition to cancer. But there's, I reassure people that the conversation isn't just going to end when they're told they have a diagnosis. It's going to be an ongoing relationship and care that'll, take care over a big period of their lives, which is great.
I'm kind of wondering this. We as a society kind of tamed heart disease through helping smokers quit, better medical management of high cholesterol, high blood pressure. Is there something about cancer that makes it a tougher foe when it comes to prevention?
The best way I can answer you is that, Charles Darwin got this perfect down, and everything that Darwin spoke about evolution of mankind, if you put that into a high speed gear and applied that to cancer, that's exactly what cancer does. It's so, in layman's terms, it's an intellectual, intelligent, living being that is constantly adapting to any threat that we put at it. You try and come at it with certain treatment, you try and come at it with radiation or surgery or chemotherapy, and it's constantly trying to evade, what we're doing. And it's acquiring resistance, it's acquiring different methods of evasion. So it's a constant challenge. We're also trying to see what's the best way to sequence treatment approaches for it. But it's really the fundamental of ongoing evolution that makes this the biggest challenge, known to mankind, if you ask me.
And Dr. Bolton, you had a quote in a profile I read about you, and I thought that was interesting. I feel you say, like, cancer prevention and early detection is an underappreciated area. And the reason why is because it's really hard to do. Do you have a comment about why this is such a very hard thing to do?
The problem with like treating cancer is that it has the ability to evolve. And a lot of that, I guess, evolution, it's like by the time you get cancer, cancer has this huge repertoire of like ways of evading our like immune system and evading normal, killing mechanisms. But the idea of like trying to maybe prevent cancer, like to treat it at its earliest stages, at that phase, it doesn't like have as many tricks up its sleeve, basically, to like evade or prevent, you from treating it. So there's a lot of promise there, I'd say. But it's really hard to do these like early prevention trials because number one, they it's hard to come up with like drugs that are going to be safe enough and well tolerated enough to give people as a preventative agent. Number two, it takes forever to do these clinical trials. So like, it takes 10, 20 years. So you have to have a lot of money and you have to have people that are running the trials that like accept that it's going to just take forever to do, and it's not going to give immediate, rewards. And so, and then also, even when you show that something works in the preventative setting, sometimes it can be hard to get people on board with it. Usually because there's most drugs have side effects. There's some that don't. But a lot do. And so it can be hard to convince people that the side effects are worth it. So it's challenging, practically, but also just inherently because, you have to have the right approach to make it tolerable.
I'm curious, Dr. Patnaik, how far away are we from treatments that'll be customized to the specific gene and protein changes in each person's cancer?
I think that's a reality. It's already happening as we speak. So I'll give you a simple example. There's a mutation in a gene called IDH, which Dr. Bolton is pioneering a preventive trial in the clonal hematopoiesis space. But the same mutation can also be found in a very common brain tumor called glioblastoma. It can also be found in a tumor in the liver pancreatic region called as a cholangiocarcinoma. So the same drug can now be used for a blood cancer, for the brain cancer, for the cholangiocarcinoma. And there's several examples like that. So I think there are very important advances that have been made, Kathy. But I would say that most of the genetic mutations we have encountered are not really effectively targeted. When you wait for advanced cancer, it's very uncommon that they're just driven by one mutation. Now you're dealing with, like in melanoma, there could be thousands of mutations per coding region of the DNA. And to expect one drug to come in and control or eradicate it is not feasible, which is why we're trying to get that. I call it the beautiful middle ground, where it's still not late enough to target it, but it's also at a time point where we clearly see benefit without significant harm. And so to find that equipoise is a challenge that all of us are putting in a lot of time and efforts.
Both of you are blood cancer specialists. You've devoted your careers to blood cancer. And often blood cancers can be lethal, yes. But is there something that's driving you?
A really cool thing about blood cancers, and is why I got interested in blood cancers actually, is because you can pick up these mutated stem cells in your bone marrow by just sequencing the blood. And that tells you about someone's risk of getting leukemia potentially years later. It opens up this whole opportunity to potentially intervene early to prevent people from getting leukemia down the line.
These are often lethal, difficult to treat. So the earlier, we can effectively and safely intervene, the better for the patients. But also, the second thing that I want to highlight is while a lot of these patients may not develop blood cancer, they are at a 2 to 3 fold higher risk of dying from cardiovascular disease, even after balancing traditional risk factors like hypertension, obesity, and smoking. And this is because the blood cells that are mutated, they can be inflammatory. They cause inflammation in the blood vessels that supply the heart, the brain, and so researchers, including Dr. Bolton, have shown, that these patients can more likely to have these major complications. And Kathy, as you're aware, having a stroke or a heart attack can not only affect quantity of life, but could significantly affect quality of life. So this is what makes early intervention in this field very unique. It's not just cancer prevention. It's really a holistic approach towards a more healthier living, realizing the true longevity, that individual has been genetically blessed with.
Into the future, doctors, how do you envision personalized cancer treatment being part of tomorrow's cure? What's on the next frontier here? What are you excited about, Dr. Bolton?
So, we have therapies that target like mutations in the tumor in people's cancers. And this idea that maybe we could use that earlier, these like genetically targeted therapies, when they probably would work better before people get actual cancer, like when they have a cell that's like has the mutation, but they don't yet have cancer. That's something that I'm really excited about. And we have clinical trials doing that in like really high risk populations. And I, it'll start off being small, like it'll only, these studies are going to be focused on very high risk populations, and they're going to be small. It's not going to cure cancer overnight. But, as we kind of develop more and more targeted therapies, then additively, I think it would make a difference in like our overall treatment of cancer and like approach to cancer.
Dr. Patnaik, what do you think? What's on the horizon that excites you?
Yeah, I think what excites me is the aspect. I'm a firm believer that it's not one mutation that causes cancer. I think, there's several things that are ongoing. It's what you're born with, it's what you're exposed to. It could be multiple genes. They're called as polygenic risk scores. For example, in breast cancer, people have already started implementing it. It would be my dream that if a patient comes into our clinic using artificial intelligence or large language learning, we could input, their entire data, their precision genome, and come up with a poly score that factors in what their hereditary genetics were, what their genetics in the blood space or in the tumor space, what is their diet, what is their microbiome, what is their exposures, the level of inflammation. And if we could model that and say, look, you're 40 years old, here's where you stand, here are your risks, here's what you can do to cut it down, here's what we can do to abrogate it. I think that would fit, in a very composite and holistic care model that I hope we can provide.
When we look at the future of personalized medicine, is genetic testing going to be something that we all would have to undergo?
While we as physicians and the scientific community want to do this, there are lots of barriers. A lot of these genetic tests are not covered by insurance companies. Lots of my patients are petrified with discrimination, with the genetic diagnosis for insurability. Although the GINA Act is a federal mandate that you cannot discriminate employers as well as insurance companies, I can't tell you how many younger patients will come and say, I don't want this test because I'm afraid I won't get insurance, I won't get a job. I can't tell you how much time Dr. Bolton and I spend on the phone talking to insurance companies, begging them, not to deny a genetic test that we had ordered or to get prior authorization. And there are reasons. There have to be checks and balances. I'm not being disrespectful to them, but I feel that while science is progressing, all aspects of our community, including legislation, insurance, regulatory authorities, ethics, institutional review boards, we all need to move ahead with synchrony.
How do you apply what you're learning from your own research on personalized medicine to your own day-to-day lives?
One thing that I have become very intrigued by is, the concept of the exposome. While we have the genetics, they're not everyone with the mutations or the genetics go on to develop cancer. So, the holistic approach is that it's, what we are exposed to, what we eat, what we drink. And, there are certain case exposures which have been very severe in history, like Hiroshima, Nagasaki, Chernobyl, Three Mile Island, to name a few, and, mercury exposure in Minamata Bay in Japan. And so I've, gone into depth trying to understand the epidemiological nature of those exposures, how do they alter it? And then how are these ongoing at much lower levels? There are a lot of rural communities, and Dr. Bolton will attest to this, where the prevalence of leukemia is 2 to 3 fold higher than that in urban communities. And you just wonder how much of these pesticides, chemicals, etc., that are being used, how much of groundwater contamination. So while in my practice I'm focused on the genetics and prevention, in my spare time I love reading and trying to understand these things that are happening around us.
I think being an oncologist really teaches you about to really like appreciate your life, I say, like in a day-to-day way. Because you're faced often with like people your own age that are, that are really sick, and that are, having to deal with this completely life-altering diagnosis. Like it just changes your life like completely in a moment. And it's so unpredictable. And it teaches you that I think it definitely has taught me like that the things that you worry about in your day-to-day life in the end are not the things that actually matter the most, like that alter your life, because the things that really alter your life are completely unpredictable.
Oh, I would like to leave it there. There's so much to talk about, truly, and it was a pleasure having you both on the program. Thank you so very much.
Thank you. Thank you for having us.
Subscribe to Tomorrow's Cure on Spotify, iHeart, and Apple Podcasts, or wherever you get your podcasts for future conversations.